I think we'll move on to the next talk, and our next speaker is Dr. Murugan Subramaniam, and he's a leading radiologist specialist at Coimbatore and the medical director of a very famous Clarity Center, which is extremely famous and popular in Tamil Nadu. He will be taking on an introduction of neuroimaging in neuro-ophthalmology. So, Dr. Murugan, please.
Yeah, good evening to you all, and thank you for the invitation. So, as you know, imaging plays a very crucial role in the diagnosis and management of patients with neuro-ophthalmological diseases. But unfortunately, there are so many tests, so sometimes it's very confusing as to which modality to choose for a particular clinical scenario. So the purpose of this talk is to highlight the optimal imaging combination, which will give the highest diagnostic yield, especially in an Indian scenario where we are limited with one imaging option. So as it becomes much easier for me because most of it has been touched upon earlier. In fact, this talk has been prepared keeping the residents in mind and the general ophthalmologist, so that it just gives an overview of the imaging options available and some of the queries which have been raised earlier also, I hope to address in this next 7-8 minutes. So it is MRI. MRI is the modality of choice. Of course, we have MR angiogram, MR venogram. We have CT. We will discuss where it's useful, CT angiogram, and DSA, which is a catheter-based imaging option. Now, this is some of the common indications, clinical indication: visual loss, ptosis, proptosis, diplopia, nystagmus, and your ophthalmological abnormalities. Now, this is an interesting literature. All these slides, I will say, is take-home message. In fact, this is very obvious. So this is a diagnostic and economic yield of neuroimaging, and they have clearly mentioned optic neuritis, optic neuropathy, that is slowly progressive neuropathy, and cranial palsy are the three major areas where neuroimaging plays a role. In fact, in my practice also, most of the referral from neuro-ophthalmologists is around these cases. Now, coming to CT, CT, the information with bony detail is very good. For example, this is just a collage of images. You can see fractures with bone fragment. You can see nice 3D pictures. You can see sinus disease with bone infiltration, calcification, as it was mentioned earlier, even meningioma calcification, CTs, sometimes MRI totally misses it out, and foreign bodies. These are some of the areas where CT is still useful. MRI, of course, it's very obvious because of the contrast resolution, the T1, the T2, and residents should always remember the sequences, the STIR sequence, which is the fat suppressed sequence, the FLAIR sequence, fluid attenuated inversion recovery, which is for multiple sclerosis, the plaques, and of course now the DWI, that is the diffusion weighted image, which has totally taken over the infarct imaging from CT scan. So these are the three sequences you should write in the exam if a question is asked on MRI. Coming to clinical scenario, acute unilateral visual loss, non-traumatic, they start from the afferent pathways. And the clinical scenario is optic neuritis or ischemic neuropathy. As mentioned earlier, imaging plays a very limited role for ischemic neuropathy. And many times I get questions whether it can pick up the ciliary occlusion. No. At this point, the resolution of MRI is not good enough. Even MR angiogram cannot pick up ciliary occlusion. So we are left with optic neuritis. Of course, as mentioned earlier, MRI brain with contrast is the imaging choice. And it is the STIR sequence is good for picking up optic edema, and FLAIR sequence for the plaques. And as mentioned earlier, the optic neuritis treatment trial, presence of plaques means that patient is more likely to develop multiple sclerosis, more than 50% chance. So some of the images, you can see the STIR sequence, even the plane itself, it's very sensitive. It picks up the edema here, the contrast shows the enhancement, and post-contrast, yes, even the optic chiasma, and the FLAIR sequence, you can see the multiple plaques. Now, comment about NMO, I think as mentioned earlier, it has got typical orientation or distribution in the midbrain. So I was listening to the talks, now I remember whenever there's a distribution away from this periventricular, we should probably extend the study to include the spine and not to miss the neuro-NMO spectrum disorder. Now, optic nerve injury, CT plays a role here because it helps to assess the fracture, whereas MRI is still useful to pick up the continuity of the nerve and edema. As illustrated here, you can see the nice bone fragment. The anatomy is so well brought out that will not be seen with MRI, whereas MRI is still useful to pick up the continuity of the nerve and also the contusion. You can see beautifully the contusion extending up to the optic chiasma. Progressive visual loss. Anything which is progressive, that means we are dealing with some compressive lesions. Unilateral, yes, MRI is the choice, and you can see a big meningioma, typically in the tuberculum cellular region, compressing on one optic nerve, giving rise to optic neuropathy. And some of the clinical cases, progressive visual loss bilateral, as it's mentioned clearly, bilateral optic atrophy, bilateral hemianopia. So we are suspecting chiasmal lesions, and MRI is the choice. You can see the central pituitary adenoma compressing, and you can even see the chiasma which is getting displaced. In an younger age group, we find craniopharyngioma more often. Again, homonymous hemianopia, we know that the lesion is more, posterior to the retrochiasmal, onset for 2 days, and MRI shows the infarct. Very typical. This diffusion imaging has really changed the way we diagnose infarct. And again, another patient with homonymous hemianopia, but with central sparring, has got an occipital infarct here, again in DW. And bilateral papilledema is another common indications. Of course, we are looking at CVT, neoplasm or idiopathic ventricular hypertension, MRI brain with MR venogram, which is a non-contrast study. Okay, that's the investigation of choice. This is a normal MR venogram, completely normal. We can see this completely occluded. And the point we are observing now, there's a lot of CVT coming up, as was mentioned, post-COVID, they can have thrombotic complication. And I somehow feel it is added on by the fact that we are all wearing masks and we are not taking proper hydration. Maybe that is contributing to the additional incidence of CVT in this period. This is another patient with papilledema. You can see completely normal venogram, but indirectly we find the tortuous optic nerve with distension of optic sheath, the perioptic sheath, and empty cella. When we see this, then we can mention idiopathic intracranial hypertension. Of course, this radiological finding not always correlate with the clinical observation, but it rules out tumors and other conditions. Coming to the efferent pathways, third nerve palsy is one of the common indication, as it was mentioned. Pupil involving palsy, yes, the imaging is really important, especially MR angiogram. And CT angiogram, there was a comment, and CT is definitely superior to MRI, but then the fact is, it's a contrast study, and number two, it will look at only the vessels. So, if the pretest possibility is very high, then we can go for straight away CT angiogram, but then MRI will also look at the other areas. That is very important, the brainstem, other areas. So, in Indian context, I feel MRI brain with MR angiogram should be the first choice. When we see aneurysm, probably they can go directly for DSA and coiling. Okay, so a patient with third nerve palsy with the Weber syndrome, hemiparesis, you can see the infarct nicely, the anterior midbrain. And another patient, yes, another patient, incomplete palsy, pupillary involvement, as it was requested, and yeah, there is an aneurysmal sac right here. Of course, it is better seen with CT angiogram that gives a lot of bony detail.
1 minute left.
Section. But then MRI should be the first choice. Another patient, there was somebody was asking whether pupil sparing, whether it can be asked. Yes, but if it is associated with sixth nerve palsy, yes, this patient had sixth nerve palsy. You can see that there's a large aneurysm, a large giant aneurysm. They don't bleed. They present more with mass effect. MRI angiogram shows it very clearly. If there's a combined nerve palsy, third, fourth, sixth, we know that is in the cavernous sinus. And pseudotumor cerebri is pseudotumor is one of the common presentation. You can see the contrast enhancing soft tissue in the orbital apex and cavernous sinus. Lastly, the motility disorders. In fact, internuclear ophthalmology, gaze palsy, nystagmus, where we suspect lesions in the brainstem, MRI is the modality of choice. It picks up demyelination infarct, for example. This is an infarct in the MLF region, shows beautifully that correlates with the clinical presentation. And lastly, as it was mentioned earlier, it's very important to give the clinical history to the radiologist because this patient was diagnosed before imaging. So Dr. Murugan has in fact referred this as Brown syndrome, and lo and behold, we could see the inflamed superior oblique tendon, which is enhancing with contrast. That makes things easier. We can even concentrate on the pathology. That is the importance of giving the clinical history beforehand, so that we can target the study well. So just to conclude, MRI is the modality of choice in most of the clinical scenario. CT will be useful in trauma, in bony pathologies, when we want to rule out calcifications, or when somebody is present in an acute way, acute hemorrhage, especially subarachnoid hemorrhage. Okay, thank you so much.
Thanks a lot, Dr. Murugan. There's a lot of clarity and a very interesting talk. Any questions before we go on to our next speaker? I think we may be running late.
I have one question, sir, to Dr. Murugan. Do you follow any protocol in imaging cranial nerve palsies?
Yeah, ideally, MRI with contrast is recommended. As a radiologist, I would like to use contrast for all patients. Unfortunately, unlike in Western countries where it's all covered by insurance, here, charge is a limiting factor. So, but as a protocol, MR, thin sections, protein brain, post-contrast should be the choice. Otherwise, without contrast, we can miss some of the lesions, as it was even illustrated.
Thank you.